Well, good afternoon, everyone. I'm Dennis Stone, Director of the Center for Advocacy and Social Justice at the Jacksonville Urban League, and we're excited to have you with us on our monthly conversation of racial healing and reconciliation. We have a special guest today, Dr. Waleed Zahoor, who is working with our center and is doing a presentation. I won't get into the subject matter because two of our interns, Dia Jawar and Annalise Cedeno, are covering this, and I'm going to turn it over to Dia to make the introduction. I will say on behalf of the Jacksonville Urban League, Doctor, thank you so much for joining us.
Hi, everyone. My name is Dia, and I'm an intern here at the Jacksonville Urban League. Thank you so much for joining us. So, I want a brief minute just to introduce you to our speaker for this month's Racial Healing and Reconciliation Town Hall, Dr. Waleed Zahoor. Dr. Zahoor is originally from Pakistan, where he studied at Rawalpindi Medical University and then worked as an ER physician for several years. He recently moved to the US to obtain his master's in public health in epidemiology and biostatistics with a concentration in infectious diseases from Boston University. His research interests lie in clinical medicine with a focus on infectious diseases and critical care. Today, he'll be presenting about the disproportionate impact of HIV and AIDS on minority populations in the United States. I'm excited to welcome Dr. Zahoor.
Hello, everyone. My name is Waleed, and like my introduction said, that I'm going to be presenting uh, about HIV or immunodeficiency virus at Jacksonville Urban League today. So, should I start my presentation now?
Yes.
Yeah, okay. So, HIV or human immunodeficiency virus. It's a retrovirus of the family of a virus of a novel kind of family that has been in discussion for last 30 or 40 years. Why we want to discuss this is because HIV still remains a major public health issue, and it causes a disproportionate burden in African American communities, and it also reflects the structural inequities that patients or the victims have to go through with it, and it still remains a cause of concern, and there still has not been uh, much of uh, much of its uh, I wouldn't say cure, but like it's still being hovered around and still spreading, and it is still spreading. So we are going to be talking about HIV and what it does. So first of all, we'll be talking about the brief history of HIV or human immunodeficiency virus. It was first discovered back in 1980s when the first victims of human immunodeficiency virus were uh, s- diagnosed through the viral uh, assays. And it was not that it was the first time it was discovered. It was thought to be occurring well before that time, but it was usually in the primates or the members of animal family that were carrying the human immunodeficiency virus. But it was in the 1980s that it first appeared in the human species. So, like it says, in 1983, it first appeared. Then in 1990s, it was uh, the first guidelines started to appear, and it caught the world by storm due to the massive amount of mortalities and deaths that it was causing, and with seemingly no cure for it, it caught the world by storm here. So, 30 or 40 years later now, we're still there. There were efforts of making vaccines for that or vaccinations, but we still have not been successful as far as we are concerned about HIV, that we have not been able to produce a vaccine or a treatment example that cures it 100%. So we are going to be discussing about that in detail now. So first about the epidemiology of HIV. Regarding the African Americans, they are basically 13% of the population of United States of America, and among that, 13% of them carry HIV, and they constitute 40% of the new HIV diagnosis. And there is a higher burden of HIV in men who have sex with men and also women. According to the Harrison's Manual of Internal Medicine, 1.1 million people are currently living with HIV in US. Approximately 13% of these are still unaware that they have the virus. And approximately 693,000 people with AIDS diagnosis have died in the history of the United States. Now on to the geographic patterns. How HIV is concentrated in United States is that it is on the higher spectrum or higher threshold in the southern United States, and it is more localized in urban centers of population, and it is also linked to social conditions. Now to the social determinants. The poverty and housing instability, which I have already mentioned, it is linked to that in the highest burden setting. And Jacksonville Urban League, like we said, uh, it has it has ties to poverty and housing instability, and it is working through that in to correct these things in the Duval County of the Jacksonville. And limited healthcare access is also another determinant, which is very important in here, that causes the predisposition and the spread of human HIV, human immunodeficiency virus. And education gaps are still there, that are still causing the rapid spread of the virus. And we have to still discuss them and to make it more accessible for people to get the access to the healthcare, so they can address their status and they can get more knowledgeable about the disease. Now on to HIV. It is basically caused by HIV virus, which is a type of retrovirus, a novel viruses, and there are two viruses that mainly causes them. There are HIV-1 and HIV-2. So what happens is that when this virus attacks the body, or when a person gets infected with human HIV, it attacks the cells called CD4 T cells. T cells are basically are the natural killer cells of the human body that prevents the invaders or that are attacking our human body, and they commanders against them. Uh they sort of act like the commanders and the soldiers who prevent uh the foreign invaders, and they kill them so that they do not cause an infection inside our body. It is mainly transmitted through sexual contact or the human exchange of human fluids like blood, bodily fluid exchange, and in the vertical transmission through mother to child in utero. And even though it still doesn't have any definitive treatment that can cure it 100%, but it can still be managed with the individuals who manage it, can lead to having a near normal lifespan. So HIV and AIDS. The difference between HIV and AIDS is that HIV is the virus that causes the infection and it damages by killing the CD4 cells of the body. And CD4 cells are the part of immune system. HIV attacks and kills CD4 cells. Loss of CD4 cells makes it hard for the body to fight off infections. About the AIDS is the last stage of the HIV infection. It is abbreviated for acquired immune deficiency syndrome. As HIV infection advances to AIDS, the amount of HIV in the body increases and the number of CD4 cells decreases. HIV medicines can stop HIV infection from advancing to AIDS. Without HIV medicines, HIV advances to AIDS in about 10 years. ART or antiretroviral therapy, it can prevent HIV from spreading, preventing HIV and causing a delay in the progression from HIV to AIDS. So now on to the infection and how does it cause, what symptoms or signs can appear in the body of the infected individual. The thing is that it starts off like just another viral infection that has the similar symptoms and signs that are produced by various, like even 10 or 20 other kind of infections that are very routine. It starts off with fever, sore throat, swollen lymph nodes, rash, muscle aches, fatigue, malaise, night sweats, and sometimes ulcers in mouth. It is estimated that the first infection it lasts for 10 years. And another thing about it, that even when a person catches this infection, it can still produce no effect or no symptoms, and a person can lead to be having the person will be having no symptoms at all, and it will be showing that it is totally all right, and the virus in the background will continue to divide and multiply and continue to growing on in the body. The next stage of the HIV virus is the chronic infection or chronic infectious state. It can still be asymptomatic like the primary infection, or the already occurring symptoms they persist over the years until the treatment is sought, and then it progresses to advanced stage. So the symptoms that we talked about, like fatigue, malaise, low grade fevers, rash, muscle aches, and some infections of the specific glands or areas of the body, they might still be occurring at not a very frantic rate, but they will still be occurring, and it will still probably be undiagnosed if healthcare is not sought. Next, the HIV advanced stage. So it happens when the CD4 counts in the body falls below the 200 cubic millimeter. So the normal range of the CD4 counts is in thousands. So in the first stage, it's usually all right, and in the chronic infection it starts to fall below the 1,000, and then when it falls below 400, the symptoms of the advanced HIV starts to show itself, and the body starts, it's so weak, it gets so weak that it becomes very hard for the person to not to just ignore it at that stage. So a lot of cases are diagnosed at the advanced stage, and the possible signs of the advanced HIV is are persistent fevers, night sweats, unexpected weight loss, chronic diarrhea, severe fatigue, and skin rashes. And main point of focus is that once the AIDS infection is advanced, even a simple infection or a simple disease like a common cold can take the life of the person, and it can prove fatal there. And how do we diagnose it? Various methods are used to detect HIV virus in the body. The most common is the blood tests or the saliva tests that detect HIV DNA or HIV protein or antigens or antibodies in the body of the human. Antigens are the proteinaceous materials that are shown or produced by the virus, and they can be detected from the blood in the by various tests. And antibodies are the proteins that are produced by the host cells, which is the human body, against the HIV virus, and we can detect it by several methods. These methods include ELISA or the or EIA or Western blot or PCR. PCR is the most common used method because it's very rapid and it provides a very it's like the success rate or the true positive sensitivity of that infection is above 99%. Regarding the treatment of HIV, is it treatable? Not really, but it is manageable. HIV treatment has evolved rapidly due to the rapid scientific advancements. Back in 1980s, there were only one or two antiviral drugs available, and the patients used to die within months if because there was no proper treatment available back then. But now we have a lot of regimens in place that allows near normal life expectancy of the patients. So initially, the HIV treatment, it consisted of three or more tablets or pills, and they were given three times daily with food. And what when we asked the patients who took treatment back in the day, in even back till 90s, they used to say that they used to take around 40 pills a day, and it was they would forget because there were 40 pills a day is no joke. It gets so much confusing, the regimen, like which medication I have to take now and which pill is which one. So they used to forget them all over the place all the time. So now the treatment has advanced and we have moved on towards a more simplified HIV regimen with less pill burden uh, n- and very simplified. Uh, I would say it is very simplified measure now. So now what we do is it's just one pill and which is combination of all the drugs that the person needs, and it is given once daily with no food necessary. Its benefits are usually that it is easy to adhere to, and it reduces the risk of treatment failure, and it also obviously causes the improved quality of life. And there are also fewer side effects of the HIV, which we will discuss further in in our presentation. So one of the things that we have to address is why people do not take the treatment for HIV once they are diagnosed with it. One of that is the high pill burden. Some people just do not like taking medicine pills because they think it makes them look sick. Uh, it is a valid um, it is a valid concern of theirs, and we should not be disregarding that taking a pill might be can still cause stigma. Some people may not be comfortable taking them, and there is also lack of healthcare access. There might still be facilities where proper treatment may not be available, and some people get very weak by the side effects that the medications cause. And there is also a lot of misinformation going on that HIV is a hoax or HIV is not a real disease. So there are a lot of other concerns as well. Like some people just do not believe in the treatment that is being offered, and some people think that that just because it doesn't treat the disease, it's not going to cause any effect whether they take the treatment or not. These are the common side effects of the medications that the HIV treatment currently uh, that the patients are taking. Lipoatrophy is the loss of the fat in the body, which is more pronounced in the cheeks or extremities. Now, another one of them is rash, and in the heart, it can cause hyperlipidemia and high cholesterol and glucose levels, and it can also cause diabetes. In the kidneys, it can cause kidney stones and kidney failure. In the liver, it can damage liver. The nerves, it can cause neuropathy, causing strange sensation in the feet with the burning and stinging sensations. They can cause osteoporosis in the bones, or the bone pains, or the weakening of the bones of the body. In blood, it can cause anemia, which is the low number of red blood cells, causing fatigue. In the gastrointestinal system, it can cause nausea, vomiting, and diarrhea. So one of the most interesting aspects of HIV prevention is a newer kind of term which is called U equals U, which it means that if HIV infection is treated so much that if the viral load in the body becomes undetectable, then even if a person has a sexual contact or has an exchange of body fluids, it will become untransmissible at that level if there are no if it's not detectable in the blood. So what it means that is the consistent treatment suppresses the amount of the viruses in the body to such a degree that it may not be transmitted even with exposure. And the barrier protection is still considered very safe in that regard for the patient who may not like to be uh, co- to be practicing celibacy or non or avoiding the sexual intercourse in their lifetime. Then another prevention of the HIV is the PrEP, or pre-exposure prophylaxis. This is usually a daily pill or a bi-monthly injections. So you get two injections in the body in 1 month. It is an extremely high and effective prevention, and it has been estimated that it has been underutilized in the African American communities in United States. The barriers are usually the cost and the awareness regarding it, and also the health insurances that are still not covering these kind of treatments or methods. Their insurance coverages can cause the excess gap to be widening or further in this population. So another thing about the vaccine, a lot of people say that why isn't a vaccine being developed for HIV? It has been here for like over 40 years, but it has been in the experimental stages till the 1980s. I was in a lecture a few months ago, and one of my professor, Robert Horsberg, he said that back in 1980s when we were still developing, it was estimated that we would be able to develop the vaccine in 4 years. But like he said that once they got into it, it became so much of a hassle, and it became so tough when they got things got going, that even after 40 years, it still looks like the vaccine may still be very far away. And the main reason for that is that of the inability to produce the vaccine is that the virus constantly mutates. So I would like to give the example of the various iterations of the famous comic character called Joker. So just like there are so many varieties and variations of the same character, the same thing is of the HIV virus. It constantly changes its structures or proteins, or making slight and subtle adjustments to its structure, that it just evades the foreign immune surveillance mechanisms of the body. So what happens that when you target a certain vaccine against against the virus, it just makes a certain mutation that will just bypass it, and that cycle just keeps going on and on and on. Another important aspect of HIV treatment is the stigma. There is still stigma affiliated with HIV or AIDS, and it is still called the disease of shame. People do not inform of their HIV positive status, and they fear that it reduces testing, and the stigma, it causes fear, which in turns reduces testing and care. Effects of HIV on the community is that there is higher incidence and prevalence of the morbidity and mortalities. Mortalities is basically the deaths caused due to a certain condition. And due to the HIV not being diagnosed earlier enough, the late diagnosis is more common. And lower viral suppression, because it has advanced so much further that no treatment will cause any effect on that. So uh, at that moment, even getting diagnosed with HIV is not going to do much for that. So, how do we address it? We have to increase awareness regarding the HIV. We also need to improve the healthcare access for the patients who are suffering from this disease. We also have to remove the misperceptions, and have to reduce the stigma affiliated with HIV, HIV virus or AIDS. We need to do in f- uh, more community engagement for asking the people to spread the message that it is not something in our control for those who have contracted the virus, and it is not something that is untreatable, because the treatment of it uh, will lead to a near normal life expectancy with certain uh, kind of patterns of management and lifestyle changes. And healthy behavior will lead to less transmission of virus and less catching of the virus in the patients. And one of the common populations who can get infected with HIV are the IV users, who share the needles while injecting drugs. So abstaining from that will also lead to decrease in the transmission of the virus, or the safe injection sites can also be another important measure that can be used to the address towards the dissemination of the infection. Now on to the take home message. HIV, it can still be controlled if we acknowledge the problem first. Then we need to contain it using multimodal approaches alongside empathy and compassion. So HIV is something that we can still control, and we can still make it untransmissible by aggressive treatment, but it is not a simple approach that is going to help the cause. We have to go into the different dimensions and have to use a multimodal and multidimensional approach towards the patients and towards the victims of the disease. And we have to approach those patients and those people living with HIV with empathy and compassion, so we can treat the virus and we can decrease the scourge of HIV in African American communities. These are the references that I used to compile the my presentation. One of them is the Harrison's Manual of Internal Medicine, the HIV site, the WHO site, and the CDC. Thank you.
Thank you so much, Dr. Waleed Zahoor. That presentation was absolutely amazing. Now we're going to open up to the questions portion of the presentation or Zoom meeting. I can start us off with a question or two while you guys are able to think of some, because that presentation was super elaborate and well done, and some of my questions you answered them in the presentation, so amazing job. Um, so I'll start off. I'll say, should HIV prevention, like the PrEP testing that you mentioned, be fully subsidized, and what would that look like in practice?
It's for question and that involves a lot of economics. So, as a human, I would always say that prep is something that should be available to every person because it's a question of human life, and when human life is at stake, you have to give them everything possible. So I would definitely say the prep is something we that should be available for access to every person, whether insured or uninsured. But that depends a lot on the current people in charge and what their priorities lie towards, whether they think HIV is something important enough to combat or not. So it's something not in the hands of the people, of the common people in the healthcare department, but it is something at the higher level, at the policy levels, in the higher offices. Those people are will need to do something about it. And as a human and as a healthcare professional, I definitely think PrEP should be included should be available for everyone.
Thank you. And how does the concept that you mentioned with undetectable being equal to untransmittable, how does that change like people's understanding about the risk of HIV?
It's actually very fascinating. It's a very fascinating concept. It's not just a concept because it has been proven by scientific knowledge that once the viral load drops below a certain threshold, it becomes untransmissible. So, with aggressive treatment, as we keep treating the patient and the viral load from thousands decreases to near undetectable levels, it becomes very hard to transmit, uh, even with the exchange of the bodily fluids or blood transfusion or even sexual intercourse.
Okay, thank you so much. And does anyone else have some questions for Dr. Zahoor?
Yes, I have a question. And by the way, thank you for that presentation. I learned a lot from it. And um, so looking at the bigger picture, what do you see as and I know you've mentioned some of these already, but what do you see as the major, the items that are really blocking success and improvement in terms of the proper course of action for successful improvement with HIV victims?
I think there are a lot of steps that are being blocked by the certain elements. First of all is that the people in charge are not acknowledging the problem of HIV. If they acknowledge, the first step would be to acknowledge the problem, and once we do that openly, we can start uh, moving towards the treatment pattern of that. So one of that is acknowledging the problem, and the other one is the improving the access towards the treatment and the facilities. If we improve the healthcare access to a degree that any common man can approach these novel treatments or the newer treatment plans without costing them a lot of money or from their income, then I think there will be a lot of decrease in the prevalence and the incidence and the new incident cases of HIV. So once that happens, and once we address these sort of things, like the policies and the healthcare access and the provision of antiviral therapy to the victims of HIV or the patients who are carrying these, and we also have to disseminate knowledge towards them. We also have to tell them, we have to educate them about what the HIV disease is and how it can be prevented and cured. So if we do that enough, I think we will reach a certain limit after which the curve of this ever growing curve of HIV is going to start decreasing towards zero, but it will still take a lot of years towards that. But I think we need to get our priorities right with the policymakers and the lawmakers of the world. I would say that once they do that, we will start seeing a decrease in HIV curve in the world.
So, the other question is, my sense is the legislature has made steps towards restoring funding for the drug. Is that correct?
Um, Well, certain drugs are still available, but there are the newer kind of drugs, they are not still being available, still being made available towards in every insured patient. So there are still those gaps that need to be addressed, and we're not there yet, and we still haven't received any sort of concrete or solid messages from the masses of the policymakers and the lawmakers, that we do not really know at the moment where it is headed towards. But the recent funding cuts and everything that we have heard about, it has actually caused a sort of a back. It has taken uh, it has led the HIV prevalence towards the back. It has shifted it on the backside. Nor and not that it is totally futile now, but it has gone taken a back seat now, and because their preferences and priorities are something other than HIV. They are moving more towards the minimalistic type of uh, treatment and healthcare provision rather than the maximalist, where every kind of drug and treatment plans are available.
Good. I have a question. Given your experience in Pakistan, both as a student and doctor, um, what have you noticed that's significantly different here in the United States versus Pakistan in terms of healthcare availability?
Well, it's fantastic in United States, because in Pakistan we still only have only a few clinics uh, that are like labeled for HIV clinics. Still do not have the proper first line medications available there for HIV prevention that is being used in United States at the moment. So Pakistan is actually 10 or 20 steps behind the world in that regard, because it still hasn't acknowledged the problem that HIV exists there.
Mm.
But in United States, they know everything, and there are a lot of scientific advancements with the treatment and the prevention, that there's so many of the medications are available. It's just the problem of not having everyone being equally making them accessible to everyone. So not everyone with the HIV has equal access to those medications is the problem there.
Mm. So it sounds like it has a much the stigma attached to it is much worse in Pakistan.
Yeah, the stigma and also the economy is also very lower side. So we do not even have the first line drugs available in Pakistan to address that. And the disease of shame, it's still very much true there. HIV is considered like it it's even worse than leprosy, which was used as a disease of shame back in the day
Yeah.
of like history.
Right. And then one other question, are there other countries that are doing better than the US in terms of HIV uh, prevention and cure?
I think United States is still doing very much better uh, as in terms of HIV prevention and treatment. Canada has, I would say, relatively good or better or equal healthcare system in terms of HIV, as their healthcare is very much free of cost. So healthcare access is very much available in Canada as well. Apart from that, Finland and Norway are two countries where the healthcare access regarding HIV is very much advanced as well.
Mm.
In United Kingdom, I know that there are a lot of barriers, even a lot more than some of the middle income countries, because there is a lot of shortage of proper physicians and proper treatments. Uh, it's going in a very downward direction back there.
And last, I'll ask, so we have room for others to ask questions. How did you end up choosing this as a field, as a doctor?
Well, uh, medicine is something I've always thought of that I was born into. I'm actually from a family of physician, and it was just only natural that I fell in love with medicine. But like infectious disease is something that I found myself being drawn towards when I first came to United States for my infectious diseases rotation. That was just a sort of a happy accident, I would say. In fact, I was basically it was that my rotation was in immunology, but for some reason it was
This moment of praying for a miracle because it was a massive tumor in the left side of his brain.
Ronnie, I believe your mic is on.
St. Jude, you can help make cures possible.
Hold on, I'm sorry. Hold on 1 second here. There we go. He is now.
yeah.
Very
Yeah,
good.
so I was saying that I was basically my rotation was in immunology, but at the last minute it was changed to infectious disease due to some logistic reasons. And I never actually regretted that because I actually really fell in love with the infectious diseases and how all everything about that was the stuff that I was basically drawn towards, the tailoring of the antibiotic coverages and antiviral therapies, and it was actually a new world for me because infectious disease is still a very common prevalence which is there are only two fellowship programs of infectious diseases in Pakistan, and here there is infectious diseases fellowships in almost every hospital. So it was something that totally changed my mind towards that. And ever since then, not HIV, but the infectious disease has been something that I have always I have always felt drawn towards. Another incident was the COVID pandemic era. It showed that how much we were unprepared for any kind of new disease that was there. It just told us how much unprepared we were for towards infectious diseases and how much care we were not putting towards, we were not showing our efforts towards that. And I myself dealt with COVID infection, and it was a very difficult period for me. But once I recovered, I made sure that infectious diseases was something that I'm going to pursue in the future.
Mhm. It's ironic that Dr. Fauci, head of our CDC, was he, really was a HIV infectious disease expert, and that really helped in terms of COVID. So we have, I mean, it's not sure how to say it, but we have people that have experienced HIV issues to thank for the COVID results in a way,
Yeah,
learned a lot
and
from that process.
yes, and the mRNA vaccines was something also that was a new thing that hadn't been done before, and it sort of opened a new chapter in the world of vaccines because they can be produced very, very rapidly in mass production as well. um, but their downside is that their life is for like just 1 year.
Mhm.
So we have to do what we have to do is that they need constant doses to get that full immunity require coverage to the body. So we can so it also opened the chapters of mRNA vaccines, and there is still another technology of that being developed, that mRNA vaccines for HIV are still in are now in development, that target certain epitypes or serologies of the viruses, of certain, I would say, certain flavors of HIV. They are being developed towards.
Good, great. I'll turn it back over to Dia or Annalise.
Yeah, I have one more question. I was looking for more of a prevention lens and like an early prevention program. Do you think education programs at high schools, specifically in high risk areas that may have like higher levels of minority populations, do you think those would be beneficial, or like what's your analysis of that?
I definitely think they would be beneficial. I think that incorporating HIV education program with sex ed would also be very helpful uh, in making the minds of children receptive towards this idea that uh, how how they can stay away from HIV as well, because it's just part of a healthy behavior, the HIV prevention tactics. And I think once it can be done, it will take a few years for their effects to start showing at the higher level.
That was all the questions we had. Does anyone else have any questions they would like to ask Dr. Zahoor? Okay.
Well, hearing that, I just
Yeah.
wanted to thank you, Dr. Zahoor, on behalf of the Urban League and the Center for Advocacy and Social Justice for the presentation and all the work you're doing with us this semester. We really appreciate your presence and your willingness to help us in some new areas and be a leader in those areas. So thank you.
Thank you so much for that, and it's really great to have you as a mentor for uh, my uh, my internship here. It's been great. uh, I would say like 3 months into my internship. I've really thoroughly enjoyed this semester here.
Well, thank you. And also want to thank Annalise and Dia and Sadia Barge for all the work you're doing to make these things possible.
Yeah, super professional, I would say.
Yes.
No, you are super professional. Oh my goodness, that presentation was amazing. It covered all the boxes, and you definitely know what you're talking about when we're talking about, viral infections. And I find it so interesting. Now, I'm not built for the medical field, but it's glad that it's great that you have that drive. It's so interesting, especially studying something like viruses that are constantly changing. That seems like constant work. You have to keep up with it to prevent and to help people. So really impressive. Thank you so much for speaking about this and enlightening us about things that I definitely never had any clue about just how deep HIV and AIDS, how complex it is.
Thank you so much for that. Regarding the presentation, it's still a work in progress for me. There are some days I can talk like effortlessly into for hours for a presentation, and there are sometimes my voice just kinds of gets stuck in the throat, and I don't know like I still practice a lot for them, and it's still a work in progress that I'm still looking to improve massively in the future as well. Thank you so much for that.
Did a wonderful job. Thank you.
Okay, well, if no one else has any questions, thank you guys for all attending and listening to Dr. Zahoor and joining us at the Jacksonville Urban League. If that's it, I'll let Mr. Dennis Stone take away the conclusion.
Sure.
Thank you.
Again, thank you. And so again, on behalf of the Urban League of Jacksonville and the Center for Advocacy and Social Justice, thank you for your presentation. And those of you listening on YouTube, be sure to subscribe because we have lots of great programs like this going forward, and visit our website, our YouTube channel. We have, I think, a lot of videos that you'd be interested in. So